Hola a todos, bienvenidos a otro más de nuestros webinars. Para aquellos que no me conocen o es la primera vez que se conectan con nosotros, TICPROP es un proyecto que nació porque queremos hacer crecer la educación en toda Latinoamérica y empezamos por Costa Rica, pero hemos tenido un gran auge gracias a todo el soporte de Healthcare Training Experience. Hoy tengo el honor y placer de presentarles a mi mentor, Eddie Fan. Para todos los que han leído alguno de esos papers, es súper brillante, un intensivista increíble, top en el mundo, pero además de todo una persona a la que tengo el placer de llamar mi amigo y mi mentor y una excelente persona. Nada más, un par de detalles para el día de hoy. La transmisión o la charla del doctor Eddie Fan es en inglés y va a haber traducción simultánea al español. Entonces, para que se puedan conectar, hay un icono en la parte de abajo de Zoom que dice Interpretation o Interpretación. Y si no les sale de una vez, se pueden ir a los tres puntitos que dicen más. Y ahí van a abrir el que dice Interpretation o Interpretación y van a poner el canal que quieran escuchar. Ponen el canal en inglés si quieren escuchar la charla directamente en inglés o ponen el de español para que puedan escuchar la traducción simultánea. Y si tienen alguna pregunta, hay una caja de Q&A, de Questions and Answer, donde pueden poner las preguntas y al final de la charla yo le voy a leer al doctor Fan las preguntas en inglés, pero también va a haber traducción simultánea en el canal de español. Entonces, muy importante para todos que escojan el idioma en el que quieren escucharla, ya sea inglés, que es el original, o español, va a ser la traducción simultánea. Entonces, ya sin más, les presento al doctor Eddie Fan, intensivista de adultos en el Toronto General Hospital y el jefe del programa de circulación extracorpórea o ECMO. Entonces, le paso la palabra al doctor Eddie Fan, que agradecemos mucho por estar aquí.
Thank you so much, Deanna, and thank you for the kind invitation to speak today. I apologize that I won't be able to give my talk in Spanish. It'll probably be worse than it is in English, but hopefully I'll try to speak slowly so that the interpretation can do its job. So today I'm going to speak about ECMO for severe ARDS, current evidence and future directions. Here are my disclosures. I won't be speaking about any specific devices or products today in my presentation. Okay, the first thing to start off with is often when we think about ECMO, we want to talk about where a certain therapy has come from. It's good to start from the beginning. And the interesting thing about ECMO is that as much as it seems to be very popular nowadays, and certainly after the H1N1 flu pandemic in 2009, and certainly after the COVID-19 pandemic of a few years ago, its use of ECMO has really exploded. It's actually a very old technology. So here is a paper from 1978 showing, you could see here a large animal. I think it's a sheep that's undergone a tracheostomy and is being supported by an extracorporeal circuit. And the interesting thing is that this paper, published in 1978, so almost 50 years ago, the title of it was An Alternative to Breathing. So lots of what we think about ECMO today in the use and its use in respiratory failure, these ideas have been around for a very long time. And you can see that this article is really authored by pioneers, giants in the field of ECMO, including Ted Koloboff, who was working at the time in the National Institutes of Health in Bethesda, Maryland, and joined then by Luciano Gattinoni from Milan, but went to Bethesda to work with Dr. Koloboff for some years, learning the technique of extracorporeal support. And what you could see here in this paper is that even 50 years ago, they said, were asked questions that we still are trying to answer today. They don't know if you put patients onto ECMO, if you even need to ventilate the injured lung. And they wonder whether using ECMO for the long term could really have a major impact on the practice of pulmonary ventilation, especially in difficult cases. And certainly in our clinical experience today, that's exactly what we think about when we think about ECMO. We're using it in some of the sickest and most severely injured patients. But just to say, it's interesting to see that even 50 years ago, when this technology was new, they were already thinking about the same things that we're thinking about today. So I'm going to talk about the current evidence for ECMO. And again, of course, the story begins with how we connect ECMO to patients with respiratory failure. This is a nice review article from one of my colleagues, Lavina Munshi, here in Toronto, showing in 2025 really the three main ways you can put a patient onto veno-venous ECMO for respiratory failure. So the first thing to notice is that we're talking today mostly or almost exclusively about veno-venous or VV ECMO, because in patients who have respiratory failure, we're trying to just support the lungs, which this mode or configuration of ECMO does, and we don't necessarily need to support the heart and lungs, which would be a veno arterial ECMO setup. So we're talking about VV ECMO. And here again, in this figure, you could see the three different ways that you could connect a patient to VV ECMO. The most common way is here on the left in panel A, where you have two cannulas. So one here that is draining blood from a very large central vein, here the right femoral vein. It's sent by a centrifugal pump. The blood is drained by a centrifugal pump or impeller and sent to an oxygenator or membrane lung, where oxygen is added and carbon dioxide is removed. And then now arterialized blood is pumped back into the venous system, here the right internal jugular vein, where then it goes to the right heart. So again, the right heart has to be working to pump the blood into the pulmonary circulation, gets to the left heart has to be working to pump the blood into the systemic circulation, where then it can help to oxygenate organs and provide oxygen delivery. And so this is the most common way in many centers of the world, using two different cannulas, two different veins, but the same sort of circuit setup to support patients with VV ECMO. Another, I would say, popular but not as common method would be here in panel C, which is where you combine those two cannulas into a single large cannula. We call this a dual lumen. So it's basically like a very large dialysis catheter, if you will. So both lumens are in a single cannula that sits here in the right internal jugular vein. And what you could see here is that in the diagram here is in the inset, is that so this cannula has a drainage lumen in blue, which is much larger than the reinfusion lumen, which is in red. And what you could see is the cannula sits in the cava. So there are drainage ports proximally that drain blood from the SVC, the superior vena cava. There are some holes in the distal part of the cannula sitting in the inferior vena cava, draining blood from there. And then in the middle is a reinfusion port that typically when you put this cannula in, you direct it using transesophageal echocardiography to have the blood return directed at the tricuspid valve, where then again it goes to the right ventricle, into the pulmonary circulation, left heart, systemic circulation, so same idea. Some of the advantages of this setup are that you don't have to put a big cannula in the groin, in the femoral vein, and that might be useful in patients who you think you could wake up, maybe get them mobilizing. It's a little bit easier to mobilize patients if they're not having a large cannula in their groin. But otherwise, the system is the same. Blood is drained by a centrifugal pump, sent to a membrane lung, where oxygen is added and carbon dioxide is removed, and then that blood is returned again here in that same cannula in the reinfusion lumen to the heart. Okay, so in our center, for instance, we use this kind of setup commonly in patients that we're bridging to lung transplant. Okay, because again, those patients almost always can wake up, they can engage in physical therapy and rehabilitation while they're waiting for their transplant, so they can be in the best physical shape that they need to be in following their transplant. In the middle, you could see again probably the least common setup, which is the femoral approach. This actually is a very common setup used in a large ECMO center in Australia at the Alfred Hospital in Melbourne, where intensivists are the main people who are cannulating patients for ECMO. And here you put the drainage cannula again here in the right femoral vein, same centrifugal pump, same membrane lung, but here blood is returned to the venous system through the left femoral vein, okay? And because they're both in the venous system and they're both cannulas are in the vena cava, you might have some recirculation. So it's a little bit of a more complex circuit. But again, this might be a very fast way to put patients onto ECMO because again, you're using all percutaneous insertion, ultrasound guidance, accessing the femoral vessels. So that's one of the reasons it's common in, or maybe more common in centers that are using intensivists to cannulate. And certainly another common scenario is to use this setup in the operating room, where, for instance, you're using ECMO to support patients who are having complex airway surgery or complex lung surgery. So because the operative field is here in the upper body, then having the cannulas down in the groin area makes it a little bit easier to do the operation. So these are the three main ways that we can connect patients to VV ECMO, but developed in the 60s alongside cardiopulmonary bypass by, again, pioneers like John Gibbon working in Philadelphia for cardiopulmonary bypass, which was used in the operating room. And then these were systems that were designed to be used outside of the operating room to support failing hearts and failing lungs. And again, even 50, 60 years ago, they recognized that, hey, this machine might be even better than putting patients onto mechanical ventilation, or certainly perhaps in those patients that we put onto mechanical ventilation with severe lung injury and respiratory failure who are not doing well, this might be an important alternative. So what they did even then was to investigate the efficacy of this system in a randomized controlled trial. So in the 1970s, the National Institutes of Health in the United States had 8 centers randomize patients to receive ECMO therapy. So this is the very first randomized controlled trial of ECMO in adults with severe respiratory failure. And again, if you just make note of the authors here, these are really all the pioneers of ECMO therapy. So you can see Warren Zapel from Boston, not only of ECMO fame, but also one of the pioneers in the use of inhaled nitric oxide. Bob Bartlett, working still in Michigan. Helen Morris in Utah, Don Hill in California. So many of the leaders at the time in ECMO therapy. And the idea here was to take patients, adult patients with severe respiratory failure, and then randomize them to ECMO and mechanical ventilation and compare that to best mechanical ventilation alone. And so what they did was they randomized 90 patients, 45 to ECMO and mechanical ventilation, and 45 to mechanical ventilation alone. And what you could see here in this graph is actually survival. So survival in both groups was 10%. So 90% of patients died in both groups. Okay, so this was a major challenge, really put the brakes on the enthusiasm for ECMO in the 70s, because it told us two things. One is that if you're an adult in the 1970s with severe respiratory failure, you were in big trouble. Mortality is 90%. And unfortunately, it didn't look like ECMO was going to help you, right? Because it didn't change the mortality at all. So again, needless to say, this trial actually put a lot of places that were interested in the technology, put them on hold, because the results of this trial suggested really few benefits for ECMO and lots of complications. And it wasn't until many years later that, again, a different pandemic now, at the time I used to give this presentation, this was the pandemic, but now this is the older pandemic, in 2009, the H1N1 flu pandemic, which hit many jurisdictions around the world very severely, hit Australia, New Zealand, and the Southern Hemisphere first. And we had reports like this, where lots of patients, many of them young, healthy, some of them pregnant, were arriving at the hospital with very severe hypoxemia, life-threatening hypoxemia, and were not responding well to all the conventional measures like mechanical ventilation and other adjuncts. And so some of these patients, because the doctors felt like they were going to die if they didn't get something more, were put onto ECMO. And this is one of the high profile case series that showed in Australia, New Zealand, that showed 68 patients who received ECMO. And interestingly enough, 71% of patients survived in this case series. So in 1979, 10% survived. And then fast forward to 2009, and 71% patients survived. Now, there are major differences because this isn't case series, an observational study. It's hard to draw any firm conclusions about causality here, but certainly with a very dramatic difference, you could see that something had changed. And of course, we know that a lot had changed from 1979 to 2009. Our understanding of respiratory failure had changed, the physiology, the way that we ventilate patients, all the other supportive therapies that we provide in the ICU, a lot of advances had occurred, but advances in ECMO technology had also occurred. Systems were safer. We're using less anticoagulation, less transfusion. We better understood the interaction of the ECMO device with the patient to reduce complications. So a lot of things that changed that could explain perhaps why there was such a dramatic improvement in survival in 2009 compared to 1979. But we need better evidence. And of course, that came in the Caesar trial that was led by Giles Peake, a cardiothoracic surgeon working at the time in the UK. He's now working in Florida. But he led this very first modern randomized controlled trial of ECMO therapy called the Caesar trial. And again, at the time that Giles was conducting this trial in the United Kingdom, in England, Leicester, which is the center he worked at, it's in the middle of the UK, was the only adult center in the entire country that provided ECMO for respiratory failure. So this trial was a pragmatic randomized controlled trial where they looked at sending patients, treating patients with best conventional mechanical ventilation wherever they showed up in England, or if they were randomized to ECMO, they were transported to Leicester where they got ECMO. Okay. So in this trial, they had 180 patients, 90 randomized, as you can see, to conventional management, 90 randomized to ECMO. Their primary outcome here was 6-month survival without disability. And indeed, they showed a significant benefit for the group that got randomized to ECMO in improved 6-month survival without disability. The key challenge here is this little asterisk here beside the ECMO, because of the 90 patients that were sent to Leicester for ECMO, they didn't all get ECMO. Okay, 25% of those patients actually got better because they changed the ventilation, maybe they proned the patient, they changed the sedation, they gave nitric oxide, they did some other things, and 25% of them actually responded and never needed ECMO. So the challenge here is that this was less a trial in the end of ECMO versus no ECMO, which is the question that we wanted to answer, but it was more a trial of if you send sick patients to an expert center that could give ECMO, that seemed to be the thing that led to the benefits here. So a lot of skeptics after the Caesar trial, even though it showed a benefit in its primary outcome, weren't sure that it was the ECMO that was leading to those benefits. Maybe it's just being referred to a center that has expertise in the management of these patients that really led to the benefit. So we had to fast forward again, finally, to the second modern randomized control trial, which is on the left here, is the Eolia trial, led by Alain Combe from Paris, who really wanted to pick up on some of these challenges that were argued about in the Caesar study and really tried to provide a definitive answer on the question of whether ECMO versus no ECMO is beneficial in adults with severe ARDS. So that was the idea behind the Eolia trial. We were also fortunate to be a study site for this trial in Toronto. And the idea is here that, again, expert centers that had already been experienced in providing ECMO for respiratory failure, the goal was to randomize 331 patients to either ECMO or best conventional mechanical ventilation. The primary outcome was 60-day mortality. And what you could see here actually in this Kaplan-Meier curve was that after 249 patients were randomized, the trial was stopped early for futility. And futility here isn't futility of the procedure. It was futility. They did a simulation to show that even if we waited and enrolled to 331 patients, which was our goal, we were unlikely to show a statistically significant difference. And so what you could see here again is that the almighty p-value was 0.07, so not significantly different, even though there was a nearly 11% risk difference in mortality in favor of ECMO. And in fact, even most of the secondary outcomes were in favor of ECMO. There was even less ischemic stroke in the ECMO group. So all the signals of the trial pointed towards a potential benefit for ECMO, but it wasn't statistically significant. We don't have time today to talk about the pros and cons or the benefits or risks of looking at clinical trial results basically as a yes or no, good or bad, based on the p-value. I don't think it's a very good idea. But nonetheless, it was interesting because at the time, Jeff Drazen, who was the editor of the New England Journal wrote an editorial that sort of suggested this was the most positive negative trial there could be because the results were almost all in favor of ECMO, even though they didn't quite reach statistical significance. So when we don't get the result that we want, we look to secondary analyses to see if they support the hypothesis that there is a benefit for ECMO. So I won't go through all the details, but here on the right, you could see some representative secondary outcomes that all turned out to show a benefit for ECMO. So the first at the top was a Bayesian reanalysis of the Eolia trial results led by one of our colleagues in Toronto, Ewan Gallagher, which again showed that across a range of prior beliefs about how good ECMO was, from people who were very pessimistic about ECMO to people who are very enthusiastic about ECMO, there was an over 88% chance that ECMO was going to be associated with a benefit. And then, of course, we did traditional study level meta-analyses, individual patient data meta-analyses. And here's just one example now, I think, of 5 different network meta-analyses that all showed a significant benefit for ECMO in patients with severe ARDS. So the evidence base was building towards the benefit. And of course, the challenge is that some people who are still skeptical said, I'm going to wait for another trial. Okay. And I'm here to tell you that I think, unfortunately, that the likelihood of that is very low. And here again is our colleague and friend, Luciano Gattinoni, who unfortunately died, as you know, earlier this year, who wrote this editorial with Michael Quintel, telling us that feasibility is the major challenge for conducting clinical trials of ECMO. Okay, so the Caesar study took almost 9 years to complete and only enrolled 0.03 patients per unit per month. Eolia was a little bit better, so double the rate, but it still took almost 6 years to complete, and we didn't even enroll to our goal or target sample size of 331 patients. And over the years that it takes to run these trials, there are secular trends that changes in the management of these patients can occur. Eolia was a great example. In the middle of Eolia, Prosiva was published that shown the significant benefit of prone positioning. So in the middle of the Eolia trial, we had to change the protocol to incorporate prone positioning as a part of the new standard of care. So even though these trials are randomized control trials, you could still have threats to validity because other things are changing about the care of these patients if the trials are taking a very long time. And if we wanted to confirm the 11% absolute risk difference in Eolia, it would take almost over 600 patients. And even if you had 100 units around the world working on this at these sort of low enrollment rates, it would take almost a decade to complete. So this is the best data that we're going to have as clinicians treating patients with severe ARDS to work with to understand whether we should be using it or not. During COVID-19, there were lots of questions, again, given that uncertainty, whether we should or shouldn't be using ECMO in these patients. Maybe COVID was different. Maybe patients with COVID were sicker. And certainly early in the pandemic, reports from China suggested that mortality from COVID patients getting ECMO was nearly 100%. Now, of course, when you looked at the details, it was because they were overwhelmed, like many places in the world, with the number of COVID patients that they had, and they were using ECMO very late in patients who already developed multi-organ failure and were unfortunately likely on their way to dying. When we used more traditional criteria for ECMO in these patients, there seemed to be a benefit. And so here again are just 3 examples to help, again, increase our confidence in the efficacy of ECMO for severe respiratory failure. During COVID, we were unable to organize to do a randomized control trial, but we did the next best thing. We took data from jurisdictions around the world and we emulated or we simulated a clinical trial, something called target trial emulation, which is the next best thing. And so the top, you could see there was a trial emulation from the United States, from the Stop COVID investigators, one from our colleagues in Paris, and then one that we conducted led by one of my graduate students, Martin Erner, using global data from John Fraser's COVID-19 Critical Care Consortium. And again, all 3 of these target trial emulations showed very consistent results. Here's just the example of our study here that showed again that when we looked at putting patients onto ECMO with the same criteria as in the Eolia trial who had COVID-19 versus not, there was a 7% risk difference in favor of ECMO. And again, it also led to a benefit in these patients leaving the hospital alive. We conducted a number of sensitivity analyses in this study that showed that the result was very robust. And again, it was very consistent with the results from the other target trial emulations and the results from Eolia. So increasing our confidence that indeed, when you use ECMO with the same criteria, you can get very similar results even in COVID-19. So the end result of all that is that at least now our clinical practice guidelines from Europe and North America suggest that we recommend that we should be using ECMO in severe ARDS, either due to COVID-19 or not due to COVID-19. And these patients should be, when possible, treated in an ECMO center that is experienced to providing ECMO and adheres to a management strategy similar to that used in the Eolia trial. And again, very similarly, when we updated the American Thoracic Society recommendations, we again recommended the use of ECMO for patients with severe ARDS, again, adhering to the practices or inclusion criteria used in the Eolia trial. So at the end of the day, again, when we're thinking about ARDS, we still need to use, this is a bit of an older paper, but still has the same message, which is that we still want to use all the evidence-based strategies that we know prior to ECMO, including low tidal volume ventilation, higher PEEP, prone positioning, perhaps a trial of neuromuscular blockade, and in patients who are still hypoxemic and don't have contraindications, those are the patients that we want to consider for ECMO therapy. I think it's important to not only think about mortality, which is a short-term result in these patients, but of course the idea is to make sure that even amongst patients who survive, that when they leave the hospital, that they're doing okay. And it's interesting because we need to think a little harder about what ECMO is doing to some of these patients. So this is great work led by my colleague, Carol Hodgson in Australia, looking at 6-month outcomes in patients who received ECMO. And I want you to focus on panel C here on the right, which is looking at VV ECMO, okay? And this is looking at the outcome of disability, okay? The interesting thing is that usually when we think about candidates for ECMO, we're selecting pretty healthy, pretty functional, living independently, few comorbidities, these kinds of patients. So they don't usually have a lot of disability at baseline. So we think that, if we could treat them aggressively, hopefully we can get them to survive their ICU stay and have very little disability. So the interesting thing from Carol's study showed that indeed about a third of patients actually at 6 months who survived transitioned to have moderate or severe disability after getting VV ECMO for respiratory failure. So we really need to better understand that certainly it seems ECMO has a benefit for short-term mortality, but clearly is also associated with problems with long-term disability. And we need to better understand why some of these patients are moving from no disability to moderate or severe disability, because of course, we want our patients to have the best outcomes possible. I think something that's very important, certainly in many jurisdictions of the world, especially places like Latin America and South America, is understanding the costs associated with delivering something like ECMO, which is a very resource-intensive and costly intervention. So it's important to understand the cost effectiveness of this therapy. So this is a study led again by one of my former graduate students, Callie Barrett, working in London, who actually showed that at least in a North American context, so I apologize here, but using Canadian figures, is that you could save, based on the estimates from the data that we have from Caesar and Eolia, you could probably save about 4 quality adjusted life years. So not just saving a life, but with poor quality, but saving good quality of life years. And when we put that into a standard formula for understanding cost effectiveness, so this is something here called the ICER, or the incremental cost effectiveness ratio. In Canadian dollars, it costs about $40,000 per extra quality adjusted life years. And again, at least in North America, anything that costs less than $50,000 or $100,000 per quality adjusted life year would be considered a cost-effective analysis. To give you a sense, this is actually a less amount of money for quality adjusted life years than something like chronic dialysis for renal failure. Okay, so at least in our North American context, we consider this cost effective, but more work needs to be done considering the resources, the burden on caregivers, what happens when they leave the hospital and return to society. These are things that we also need to better understand in future work. I want to speak briefly about, moving from VV ECMO to other forms of respiratory support, extracorporeal support for respiratory failure, and that's using lower flow devices, so-called extracorporeal CO2 removal or ECOR devices, where you're not using big cannulas, you're not using high blood flow rates, but really the focus is that more closer to something like continuous renal replacement therapy or dialysis in the ICU, where you're actually, because you're using lower blood flow rates, you're actually just removing CO2 and not so much focused on oxygenation. And again, when you look at the pictures, you connect it basically like you would connect a patient to dialysis. So if you look at panel A, you basically have a catheter now that's like a dialysis catheter. It's got a drainage lumen and a reinfusion lumen, just as we looked at before. And again, sent with a similar system, centrifugal pump to the membrane lung. Here, mostly CO2 is removed. There's really not very much oxygen added because of the low blood flow rates. And then that decarboxylated blood is returned to the right heart, pulmonary circulation, left heart, systemic circulation. And again, in 2025, most of the modern CO2 removal systems that are available now use this kind of VV CO2 removal system that you see in panel A. Older systems that were pumpless used to cannulate the artery and use the patient's own cardiac output to pump the blood across the membrane lung to have CO2 removed, and then that decarboxylated blood was returned to the vein. But these systems, because they have more complications associated with them, because you have to cannulate an artery, they're less commonly used now. And the idea behind this, again, of course, is that we think that one of the challenges is that as we try to provide more lung protective ventilation in patients with ARDS in the last 50 years, we know that one of the biggest improvements in the care of these patients is the delivery of lung protective mechanical ventilation, is the idea that if we keep reducing the intensity of mechanical ventilation to avoid harming the injured lung, whether that's reducing tidal volume, reducing plateau pressure, reducing driving pressure, at some point you won't have a lot of effective ventilation, and you'll get hypercapnia, you get respiratory acidosis, and that could be a problem for the sick patient. So what if we wanted to reduce intensity of mechanical ventilation, but could manage the hypercapnia and the respiratory acidosis with a machine that cleared the blood of all that CO2? That's the idea behind these extracorporeal CO2 removal devices. And indeed, when you look at the Eolia trial, which we talked about already, and you look at the supplement, you see some interesting hypotheses about why this might be useful. So when we look at things like hypoxemia, we often think that ECMO is saving the life of patients who are dying of hypoxemia. When you look at the PF ratio here, dichotomized at 66, which was the median, you see that actually the mortality benefit wasn't very different, 43% and 42%, amongst patients who at baseline were very hypoxemic, PF ratio less than 66, but a very big mortality difference, almost 21% here, right, amongst the patients who are less hypoxemic. So maybe ECMO isn't doing its biggest effect on fixing hypoxemia. Maybe what it's doing is that when you put the patient on ECMO, you can rest the lung, you don't have to ventilate it very much, and therefore we could reduce ventilator-induced lung injury in these patients. And that hypothesis is perhaps a bit confirmed by this idea of looking at the baseline driving pressure in these patients. Again, in patients who had relatively low baseline driving pressure, below 16 centimeters of water, really no difference in mortality, 32% versus 35%. But in patients who started off with a very high driving pressure, so they're already at risk of injurious mechanical ventilation, you could see that there was an 11% difference in mortality in that group. So again, driving this idea that maybe one of the main benefits of ECMO in these patients is the ability to reduce the intensity of mechanical ventilation further once you put them onto ECMO. So then the idea, of course, is like, why don't we do that as a routine in ARDS patients? Maybe that would be helpful if we can use this device with lower blood flow. It's more like dialysis. It uses smaller catheters. Maybe it's a bit safer, easier to do. And then we can reduce mechanical ventilation further, and maybe that'll lead to benefits in these patients. So that was the whole idea behind this trial I'm sure you're familiar with. called the REST trial, led by James McNamee and Danny McCauley in the United Kingdom. And the goal here was to randomize 1,100 patients. So it would have been the largest trial of mechanical ventilation and the largest trial of extracorporeal support ever conducted. And they want to randomize patients to conventional mechanical ventilation, so 6 mils per kilo predicted body weight, so standard lung protection, versus using CO2 removal device to reduce tidal volume to 4 mils per kilo predicted body weight. So again, the idea of providing a bit more protective ventilation in this group. This trial, as you could see from the Kaplan-Meier curve, was stopped early again at 405 patients, both because of futility to show a signal, but also because of a signal towards harm in the CO2 removal group. So you can see here, mortality was higher in the CO2 removal group than the mechanical ventilation group. So 42% versus 40%. Ventilator-free days were lower in the CO2 removal group. And probably most importantly, there were significantly higher numbers of intracranial hemorrhages in the CO2 removal group. So complications were higher, and that was likely driving some of this mortality signal. And that was despite, when you look on the left here, that by day 2, they did reduce tidal volume to 4 mils per kilo predicted body weight in the intervention group. And that did lead to a very small 2 centimeters of water on average drop in driving pressure. So even though they met their physiologic goals, that didn't translate into benefits for patients because there were more adverse events in the CO2 removal group. So I think in the end, at the moment, we only want to use CO2 removal in patients who are enrolled in trials to understand what the risk-benefit profile is. But certainly, this trial tells us that perhaps we shouldn't be using this kind of device or this kind of strategy, but it doesn't mean that the idea of having a device that could be safe and remove CO2, that might not lead to benefits for these patients in a future state. And indeed, there are a number of clinical trials now running to test this hypothesis using different strategies and different devices. Okay, I want to finish with a bit of what's next, and then answer any questions that you might have. So I think now that we know and our guidelines suggest that we should be using VV ECMO in patients with severe ARDS, we want to better refine who are the right patients to put on. Like, who are the ones that are going to benefit the most, and try to avoid putting VV ECMO on patients who might benefit the least, or certainly ones that are more likely to get harmed. And some of that, again, is like things that I think are not too surprising to you. One is age. We know that the older patients are, the more likely they are to have complications, and the more likely they are to have bad outcomes from something like ECMO. So this is a nice study led by one of our colleagues here in Ontario, Shannon Fernando, using data from ELSO that showed that as you increased in age, your mortality was higher. But the interesting thing, the reason I show this, is that even at we would still consider young age, right? So when they used ages 30 to 39 as the reference group, even going to age 40 or 50, which still is very young, these patients still had worse outcomes than those younger patients. So there wasn't like a threshold where it's suddenly at like age 65 or 70 mortality increase. It steadily increases, even beginning at relatively young ages. So it's something to think about, that there is a mortality increase even at relatively young ages. We had a lot of questions about the impact of BMI, certainly as more and more obese patients come to the ICU with respiratory failure. Certainly during COVID, there was a lot of questions about whether there should be a maximum BMI for ECMO, whether higher BMI was associated with more complications. Certainly in COVID specifically, it seemed that obese patients did worse rather than non-obese patients. But again, at the end of the day, this very nice study, again, led by Greet Hermans in Leuven in Belgium, using ELSO data, showed that, in fact, there isn't really a clear association between higher BMI and mortality. But certainly what it seems is that patients with higher BMI had more complications when they were on ECMO. So this important study really changed the work at our center, where during COVID, we actually had BMI cutoffs for ECMO during COVID. But since the publication of this study, we've gone back to our pre-COVID situation where, again, if it's just a high BMI by itself without any other problems in the patient, presuming that cannulation can happen, we wouldn't exclude a patient just because their BMI was very high. I think another contentious issue is refining our understanding of when is the right time to do ECMO and when is it too late to do ECMO. So similarly, during COVID, there was a lot of pressure to get patients onto ECMO sooner because the data previously had suggested that after about 7 days, perhaps the benefit of ECMO was less if they've already received a lot of mechanical ventilation or high oxygen. So again, in a secondary analysis from our study during COVID, we actually saw that there was a benefit of ECMO even up to 12 days, probably 14 days. So again, the idea that just arbitrarily saying that at day 7, it's good, but then after day 7, they're no longer a candidate is probably not a good idea, right? It's a bit strange to think that somebody who's had 6.5 days of mechanical ventilation is a candidate, but someone who's had 7 days and 3 hours of mechanical ventilation is suddenly not a candidate, right? So again, the idea that in and of itself, using a very arbitrary timeline as a cutoff is probably not a good idea. And then finally, we have, we can develop very sophisticated ways to try to identify the patients who could benefit from ECMO the most, and then try to identify those patients who might be harmed by ECMO the most, and avoid giving ECMO to those patients. And this is the idea of looking at heterogeneity of treatment effect, and now using things like artificial intelligence or machine learning. We could take patient characteristics, like some examples here you could see on the right, like the severity of their hypoxemia, as measured by PF ratio, respiratory system elastance, so how stiff the lungs are, ventilatory ratio as a surrogate for dead space, severity of illness scores like Apache or SOFA. And basically what you could do is you could use an algorithm to sort of determine, using the data that we have, whether this patient, Mr. Jones, is likely to benefit, or maybe Mrs. Smith is unlikely to benefit. And so again, this is a nice study by our colleague Ewan Gallagher in Toronto, which showed you can do that. Actually, you could take patients from the trial and show that there's actually some patients that derive almost all the benefit. And again, here it seemed to be patients with higher ventilatory ratio, actually higher lower respiratory system elastance, so higher compliance, but severity of illness and even PF ratio didn't seem to have a big benefit. So in the future, we might use some of these more sophisticated methods to determine which are the right patients to put onto ECMO. And then in the end, as much as I told you the story of how ECMO evolved from a new technology to all these studies and then randomized trials that have led us to guidelines that tell us to use it in severe ARDS, there's still so many questions to answer. This is an older paper from 2017, but really tells you that almost every aspect of the management of patients who are on ECMO needs to be studied. How should we anticoagulate them? How should we ventilate them? How should we mobilize them? What should we do about drugs that we give, like antibiotics and sedation and these sorts of things to patients on ECMO? Are there changes because of the circuit? How should we transfuse them? All these things need to be better refined. And I bet that if we can answer or improve on some of these management strategies, again, the outcomes of these patients could improve. We're fortunate that we work in a center in Toronto where we're trying to answer many of these questions. I want to give you just a few examples of some of the amazing work that's happening and being led by my colleagues in Toronto that are trying to answer these questions. The first is this great study by Dr. Morales Castro, who's our moderator today. Really, she's on the forefront of understanding the pharmacokinetics and pharmacodynamics of drugs that we use in ECMO patients. Typically ECMO patients, because they're very sick, they're getting 10, 12, 15 different intravenous drugs, antibiotics, sedation, paralysis, other sorts of adjuncts. And so it's very important to understand this. And even today, there are still some centers that don't use sedation like propofol because they're worried about the interactions or the pharmacokinetics with the membrane lung and the ECMO circuit. So just to summarize this great study led by Deanna here was that we showed that actually the clearance of commonly used sedatives like propofol and fentanyl were actually not altered very much by the ECMO circuit. There was a bit of a change around the time of ECMO initiation, but ultimately returned to pre-ECMO levels. But probably most importantly, is looking on this data on the right, is that when you actually use semi-quantitative measures of the depth of sedation, you could see that the vast majority of our patients on ECMO were being over-sedated. Again, a very important finding, because if we want to find ways to improve the outcomes of these patients, this might be a very simple thing to start with, since almost all ECMO patients are getting sedation, if not paralysis, at the outset of ECMO therapy. So Deanna is leading a whole program of research on the pharmacology of commonly used medications in ECMO patients. So lots more results to come. Another important thing is how to get patients off ECMO once they get on. Again, and so one of the major advances in mechanical ventilation, of course, is the use of spontaneous breathing trials, standard ways to liberate patients from mechanical ventilation. We need a very similar approach for ECMO, because the longer you stay on ECMO, the more likely you are to have complications, the more resources it uses, the more costs it is. So the sooner we get them off, the better. And so again, this is work led by one of our colleagues in Toronto, Ricardo Tejiero Paredes, that showed that using a system like a spontaneous breathing trial, we call it a spontaneous liberation trial, or SLTs, could actually lead to earlier, nearly 3 days earlier, liberation from ECMO than when you just had the clinical team decide when they wanted to. And so this was an observational study that we undertook during COVID. And now Ricardo is leading, with our colleagues at Vanderbilt and Whitney Gannon, a large international randomized control trial to hopefully answer this question in the future, which is called ECMO Free. So hopefully we'll have some results about that in the future to discuss with you. And then finally, I just want to highlight that, of course, everybody always thinks about trying to get these patients up and moving when they're on ECMO. These are two of our physical therapists. This is an older patient of ours from probably over 10 years ago who was being mobilized on ECMO. And you need very experienced physical therapists to do this, because the challenges are that you can have complications. So we think that early mobility is good in all ICU patients, but certainly in our sicker patients, there could be challenges. And so again, this is great work from Carol Hodgson, who she herself is a physical therapist in Melbourne, who led this trial published in the New England Journal called Team, that in the end showed that physical therapy didn't show any benefits or in days alive and out of hospital at day 180, but there were more adverse events related to mobilization. So there are always going to be trade-offs, right? And especially in sick ECMO patients, that might be very catastrophic if those adverse events are very serious. So actually, Carol's and her colleague Lisa Higgins have just completed this international pilot study called ECMO Rehab, finished enrollment earlier this year. We're waiting for the results that'll hopefully come in the fall to help understand the safety and efficacy of mobilizing sick ECMO patients. And so hopefully more results in the future. So I just wanted to finish with the idea that VV ECMO for severe ARDS. So with the studies that we have now, it's no longer if, but when and in whom. And, you know, again, this idea that we might use things like CO2 removal in certain patients to further reduce ventilator-induced lung injury, that might lead to better benefits in some of these patients. We're still having more sophisticated ways to look at heterogeneity of treatment effects. So implementing AI or machine learning eventually into our patient data in the hospital could help us to understand who's most likely to benefit. But just to leave you with the idea that we still have many questions about almost every aspect of ECMO-related management, including, again, anticoagulation, mechanical ventilation, how to wean, the pharmacokinetics and dynamics. And we're going to need to cooperate and collaborate internationally to answer many of these questions. So with that, I'm going to finish and thank everyone for their attention. And I'm happy to answer any questions that anybody has. Thank you.
I don't know if everyone can see me here. Thank you, Eddie, for an amazing presentation. As always, it was a pleasure to hear such an expert voice about this. I have some questions from the public, and then so the first one is from Jesus Gutierrez, and he's asking, when you have a patient with lung protective and prono, and he's not getting better, and you install or start ECMO, aren't you losing time for ECMO to be more efficient? And instead of trying all the maneuvers, should we just put the patients on ECMO?
Yes. Okay. So great question. I would say we get this question a lot. So part of it is the amount of time you need to use, or maybe like you said, lose, trying some of these other things like deep sedation, higher PEEP, prone positioning. That could be pretty fast in a patient who's getting worse very quickly. So to give you some examples, and Deanna knows many of these. In our center, sometimes a patient will come to the hospital and almost immediately in the emergency department, they're on 100% oxygen, they get intubated. And in the course of 4 to 6 hours, we've already proned them, they're sedated, they're paralyzed, and they're still very hypoxemic. So they could get onto ECMO very fast. Whereas agreed, some patients, it's a little bit more insidious, right? So they come day one, they're on non-invasive ventilation. Day two, they're a little bit worse, so we intubate. Day three, they're getting a little bit worse, so we sedate and paralyze. Day four, they're still a lot better, so then we prone. And then that's 4 days goes by and you see. Um, and the only thing I would caution is that I still think that's a good idea because, again, we know that there's a tremendous benefit for many of these interventions, especially prone positioning, right? The risk reduction with prone positioning is actually very dramatic and greater than ECMO in these patients. So we should be employing all the evidence-based strategies as much as we can, but that doesn't mean it can't happen quickly in patients who are very sick. Like we don't have to wait days if in hours we see that they're failing all the things that we try. But to your point, I think there's a lot of people who wonder if just putting them straight onto ECMO would be beneficial. And so, of course, the way to understand whether that's a good idea or not is to do a trial. So one of our colleagues, Peter Rosenberger in Germany, Tübingen, has just launched an international study called the ELIO trial that's looking at answering that question. Should we put sick patients, PF ratio less than 100, straight onto ECMO? Or should we only put them onto ECMO after we've done all those other things and they're still not so good? So hopefully in the next year or so, after he's completed this trial, we'll have the answer to your question of whether if they're very sick right at the start, we just skip all the other stuff and put them onto ECMO versus waiting to use ECMO as a rescue strategy after they failed all the other things.
Great. And Sonia from Buenos Aires sent regards. And then she also says, when you have prolonged ECMO and the young patient has been on ECMO for a month without multi-organ failure and hasn't had serious complications, how do you continue until the lung improve when there's so much uncertainty?
Yeah, I think that's a great question. And of course, as you, Sonia, it's nice to hear from you. Is that exactly as you said, there's uncertainty and we don't know. And in fact, the interesting thing is, and a lot of this experience we built up in COVID is that the lung actually has a pretty tremendous ability to heal and regenerate given the time. So in your situation, as you said, if they're on ECMO and it's running well, and there are no complications, then there's no reason to, I would say, to stop or change course, really just to give more time to see if the patient will have a recovery from this situation. And again, I would say the global experience from COVID suggested that after 3, 4, 5, 6 months on ECMO, some of these patients did manage to come off of ECMO without needing a lung transplant, for instance, or that sort of thing. Okay, so lung recovery can happen in certain patients, not all patients, in certain patients, particularly in those where the ECMO is running well and there aren't any complications. There isn't, as you said, the development of multi-organ failure and that sort of thing. I think another example here, in our part of the world, we have this endemic fungal infection called blastomycosis. It's a soil fungus that can cause severe respiratory failure in some patients. And again, typically, we have these young patients who come with blastomycosis, very white chest x-rays, very low tidal volume. We put them on ECMO for 3 months, 4 months, and actually the vast majority of them actually come off ECMO without ever needing a transplant, that sort of thing. So I think exactly as you said, Sonia, in a center like yours, which is expert at the provision of ECMO, if you can have ECMO runs where there isn't a lot of complications and you can try to run it as safely as possible, good attention to the care that these patients are receiving, then that gives the patient the maximum chance for them to answer the question of will they get better or not, rather than us guessing, because there's no good way to guess which patients will get better and which ones won't.
Okay, next question from Monica Vallardo, and she's just asking about like predictors or surrogates to decide starting ECMO beside compliance or Apache scale, PF ratio. What other things would you consider to put someone?
Yeah, so at the moment, in our center, we're basically using the same criteria as was used in the Eolia trial. So it's actually quite a bit simpler in that the only things that we consider typically are the PF ratio, so oxygenation. So essentially, if their PF ratio is less than 80, quickly or slowly. So it could be 60 if it happens fast, like in 3 hours, 80 in 6 hours. Then they're candidates for ECMO if there isn't any contraindications. And the other indication would be refractory hypercapnia. So if their pH is less than 7.25, CO2 over 60, despite, again, optimizing the ventilator, sedation, paralysis, these sorts of things. So if they have refractory hypoxemia or they have refractory hypercapnia, as decided, as was considered in the EOLA trial, we would consider them candidates for ECMO. So we don't routinely at the moment consider things like Apache score or compliance or that sort of thing. Again, these could become important in a future algorithm, like say machine learning or AI, to help us determine which patients are the best candidates and the worst. That's still a research thing, I would say, but really at the moment, to decide who is or isn't a candidate, we're mainly focused on their gas exchange.
Great. And then an anonymous questions, it's asking, he would like to know about what is the maximum flow that you can have on a VPA configuration.
Okay, yeah. So in a VPA, so a venopulmonary artery configuration, it probably depends on, as usual, on the size and type of cannula that you have. That's usually the situation. I would say in our experience with VPA, which is I would say more limited than some other centers that use it quite frequently, we found that flowing at anything more than 4 to 5 liters really was limiting and typically caused quite a bit of pulmonary edema in our patients. So I would say again, the cannula and the cannula manufacturers often have specifications for what the maximum flow rates for some of their cannulas. I know some of the newer cannulas perhaps can achieve higher flow rates than some of the older VP cannulas. But again, I think it depends on the size of cannula, obviously inserted in the patient. But at least in our experience, when we've inserted the largest available VP cannula, understanding that there might be flow limitations, usually we couldn't get more than 4 to 5 liters of flow in those patients.
Great. From Eric Umaña, do you consider it useful the recruitment potential between like to decide and consider ECMO support?
I think like many things, like everything that it's a great question. Anything that you do, like something like the recruitment to inflation ratio at the bedside, like these things all help you to understand how sick the patient is, and maybe gives you a clue to your colleagues who asked the first question. It may give you a clue to how likely are they to respond to some of the things I'm about to try, right? So I think again, in and of itself, I don't know that doing a recruitment to inflation maneuver would in the end help me decide yes or no to ECMO, but might give me a clue to how much should I try or how long should I try higher PEEP if I don't think there's a lot of recruitment potential, or how much should I try a recruitment maneuver, or these sorts of things if that's something you're going to try, like how much I might expect them to respond. I might move quickly beyond those things if there wasn't much recruitability on the maneuver. But in and of itself, just like compliance or these sorts of things, I think they all give us clues to how sick the patient is. But until they meet the gas exchange thresholds, we would still wait to wait until they reach those thresholds to put patients onto ECMO.
Javier Mora is asking, what do you think about proning during ECMO? Is it useful? And if it is, which patients will benefit from it?
Yes, this is the million-dollar question. I think there was a lot, again, even before COVID, there was a lot of suggestive observational data, much of it from France. Our colleagues like Laurent Papazian and Claude Giravelli, who showed that it seemed that in sick patients on VV ECMO, that the combination of proning and VV ECMO seemed to lead to a benefit, seemed to lead to lower mortality in observational studies, seemed to lead to less time on ECMO. So maybe it improved lung healing or lung injury resolution by combining the two therapies together. So it seemed to be a worthwhile strategy. Again, as you know, because in the ICU, we've been surprised many times, like in medicine in general, when we just look at observational data, that when we do a randomized control trial, we actually get very different results. And the answer to your question is the same here. So, our colleagues in Paris, Mathieu Schmidt, did the PRONECMO study that was published in JAMA 2 years ago that actually showed that when you combine prone positioning with ECMO, it actually didn't lead to any benefits. There was no benefit for mortality. There was no benefit for time or duration on ECMO. And they looked at various subgroups to see, to your second part of your question, are there certain patients that benefit? And it didn't seem like there were any subgroups that really benefited. One of the challenges of this study was that, by the time it started, it was COVID. So most of the patients had COVID, and maybe those patients had more limited recruitability to again, the question that we had before. So at least in COVID-19, I think we can be pretty confident that proning and VV ECMO don't work together. But we're still questioning whether in other ARDS patients it could be useful. And so Mathieu has launched Prone ECMO 2, which is a new study in just ARDS patients without COVID. And so hopefully in the next few years, we'll see what the results are there. I might just make the comment that, again, it's a bit hard to know. Probably the patients who actually still have some mechanical, like some ventilation in their lung when they're ECMO, those are probably, to me, the ones that could benefit. So again, I would say, like in many of our patients, when we put them on ECMO and we reduce mechanical ventilation to very low levels, the tidal volume that's being generated is something like 30 to 50 mLs. So what will prone positioning do in terms of protecting the lung further or recruiting the lung or that sort of thing when the lung volume is such a tiny amount? I'm not exactly sure. So one of the first things I might consider is that if you were thinking about prone positioning, maybe the patients who on ECMO are still achieving some degree of tidal ventilation, that might be the group that would benefit. I'm not sure how much prone positioning would impact a patient who's basically ventilating their anatomic dead space.
Great. More questions. Sorry. Like you had like a very, very large participant record today.
No
So
problem.
it's saying, thank you for your talk. From your experience, what is the prudential time to consider a transplant? The longer the ECMO run, the higher the risk of complications like fungal infections.
Yeah, so this is also a very important question. And again, something that was really difficult to know in COVID-19 as an example, right? And I think, again, we would use again, because there's no specific way to know for sure, but I guess we would use our traditional thinking as we normally would about some kind of lung disease process that suddenly becomes irreversible or unrecoverable, right? Just like in a patient who's not on ECMO, right? So we rely heavily on the clinical evolution, like, yeah, certainly, again, to Sonia's questions, for instance, like days or weeks of no improvements and or maybe worsening would be important. The amount of lung destruction or lung like recoverable lung or intact lung that's could be seen on CT scan might be another indication. Some understanding of the the natural history of the underlying etiology of the injury, like whether that's like an inflammatory process, an infectious process, something else, or they had pre-existing lung disease under that, so their chances of maybe lung recovery are lower. Like all these things would be considered together to maybe determine when basically the patient has reached a point where there is unlikely to be sufficient lung recovery to separate from ECMO or separate from mechanical ventilation. So a transplant evaluation should be considered in a patient who could be a candidate. But that's the tricky thing, is that often we don't really know. So I think, sometimes it's very clear they have a very bad bacterial pneumonia, the whole lung is destroyed and cavitary, and there's really no intact lung architecture. That patient probably is not going to get better and separate from ECMO. So maybe a transplant could be considered earlier. But then in some of these other patients, again, I would say we've been very surprised. And again, COVID was an example where some patients on months on ECMO actually did manage to get better and come off ECMO in that situation. So again, I would say, you try to gather all the information that you have to try to best understand what you think the chances of lung recovery could be. And when you feel like there's really no chance or very little chance, then asking for a transplant opinion would be a good idea.
Okay, I have a lot of questions, so I'm just gonna pick 2 or 3 more because of the time and try to summarize what people have said. I think they are considering a lot of like how do you put into the balance, for example, a patient that has a higher PF ratio but a driving pressure of 20 versus
Mm.
someone that has a PF ratio in the 50s or 60s, but it still has a driving pressure of 12? And if you think or not that that cutoff of 60 is actually quite low, or like if they should be considering a higher value of PF ratio.
Yeah, so this is a good question and an important question about driving pressure in general. I would say, like, I think it's interesting. It's very interesting to me how quickly I think centers around the world have gravitated to the idea of driving pressure. I think it's important to remind the audience here today is that we at present don't have a randomized control trial demonstrating the superiority of a strategy targeted to driving pressure compared to usual mechanical ventilation, like looking at, for instance, things like tidal volume and plateau pressure. So in my unit, or at least maybe I'll just speak for myself instead of my unit, but in my practice, it doesn't matter to me what the driving pressure is, right? The driving pressure is not currently a criteria for or against the initiation of ECMO, right? So in the clinical trial that showed a benefit of ECMO that was based on the gas exchange parameters, so on hypoxemia or hypercapnia, and not on the driving pressure. So that thing I showed you from the supplement, it's very suggestive. It's something that could lead us to a future strategy based on driving pressure, but we need to test that. I guess this is what I'm trying to say. Similarly, like for instance, about just even ventilating non-ECMO patients according to driving pressure. Again, at the moment, we don't have a trial showing the benefit of ventilating patients to a specific driving pressure. So I think it's very suggestive. I think, again, the idea that in a patient, whatever the PF ratio that has a very high driving pressure, perhaps using some kind of strategy like extracorporeal support to reduce the exposure to injurious ventilation could be beneficial, but we need some more data to help us to understand whether that's true. Because again, ECMO has a lot of risks, as you know. So we need to be sure, we're as sure as we can be, that we have actually more benefits than harms from that kind of a strategy.
Great. And so before I said the last question, I just want to thank to the more than 250 people that join us and give us their time and learn from my great mentor, Eddie. Thanks for joining us and, for caring about your patients. Just a reminder that the next webinar is going to be on September 23rd, and we're going to be talking about sedation in the ICU with Federico Carini from Argentina. So we're going to have the great pleasure of having him. And then the last question is, do you think ECMO will substitute mechanical ventilation in the future? I really like that one.
Yeah. I think I think a lot of people are interested in that exact question. I think, I don't know. I think it's like all things, I think it's possible. And in fact, some centers in Germany a number of years ago published very small reports of a strategy like that. Like, when a patient got sick in their emergency department or got sick in their hospital and was in respiratory failure, they tried to put the patient onto ECMO before intubating the patient. And of course, at the present time, as you all know, that's a bit of a challenge because if the patient is, sort of in an emergency situation where they need either airway protection or gas exchange support, immediately, getting them onto ECMO takes a lot more time typically than intubation, right? And again, especially as I mentioned, like, ECMO is not going to do anything for airway protection if that's one of the reasons that you need to intubate that patient and put them on mechanical ventilation. So I think some things would need to change about how easy or how quickly ECMO could be deployed in some of these emergency situations for it to truly become an alternative to intubation and mechanical ventilation for acute respiratory failure. But certainly, again, like my center is a big lung transplant center. Deanna and I work in a very, very big lung transplant center. And some of these patients who have chronic respiratory failure, who could be candidates for ECMO as a bridge to transplant or these sorts of things, in those situations, the deterioration is kind of, in some cases, more predictable. And in those cases, we certainly have had situations where we put them onto ECMO before we intubated them, and that seems to work fine. But for the acute setting, I think we need to still have some technological advances to make getting onto ECMO easier before it could really compete with something like intubation or mechanical ventilation as a strategy, initial strategy.
Great. And so a lot of good comments. Thanks a lot, Eddie, for giving us your time and your expertise. It was truly an amazing talk. And I can't thank you enough for helping us always to do like Latin America teaching a great thing. And everyone says it's an amazing talk and you're an amazing expositor and expert. So I'm just echoing everyone's words. So thanks a lot again.
Well, thanks everyone. It's a pleasure. So have a great day, and I'm looking forward to seeing some of you in future meetings, especially in Costa Rica next year for El Sol Latam.
Yes. Yeah, El Sol Latam next year in Costa Rica 2026.
Thank you very much.
Okay.
Professor. See you
Bye.
next webinar also for transplantation, pulmonary transplantation.
Yeah.
Yes. Bye, everyone. Thank you.
Gracias a todos. Les dejamos la poll para que nos regalen ahí su feedback.